let's move in the spirit of disagreement to PD-L1 testing and where that fits in terms of a predictive biomarker. There's been some conflicting data about the PD-L1's reliability. Marina, can you talk a little bit about PD-L1? We have, in the US at least, a complementary and a companion indication with 2 drugs.
Did you translate that for me?
So yeah, companion means you gotta have it. Complementary, it's flexible.
And what does that mean?
Don't know. I think complementary is the first time I've ever heard this being used. It's tough for me to understand what this means. It was interesting language that I think we're all trying to get used to. Can you give us some ideas about where we stand with PD-L1 testing for the use of these drugs? Is it helpful in the second line?
Well, so I think that it is really a contentious story because nivolumab started without doing the study with a pre-planned subgroup analysis, and they created a cutoff of 1%, 5%, and 10%, but at present we don't know what will happen with 50%, for example. The study of pembrolizumab was the opposite because they used another antibody. At the beginning, they published on the New England Journal of Medicine that the cutoff was 50% of the proportion score, and now we know that is 1% again. So the Poplar with atezolizumab and also the Birch, they said that it was important not to see only the presence of PD-L1 expression on tumor cells, but also on immune cells. And if you remember, 1 year ago in ASCO, they presented the data of the Poplar, and it seemed that the good patients to give the drug were the patients with strong positivity of PD-L1, both in immune cells and in tumor cells. But if you look at the data this year of Poplar, the story with more events and with more follow-up, it seems that PD-L1 is important because when you have PD-L1, you have more chances to benefit of the drug, but you can benefit also if you have low expression of PD-L1. The same also for durvalumab. So we have at least 4 drugs, 4 antibodies, different cutoff. There is a tentative of harmonization of the antibodies. We know that at least 3 antibodies seem to go in the same direction. But we have the Ventana, which is the antibody of atezolizumab that seem to go in another direction. So we don't know what PD-L1 positive is at present.
And you're mentioning the data from the blueprint.
Yes, the blueprint, which is small. We have, but there are some data that we can draw from this small number of patients. So I think that at present it's quite difficult to give a drug according to PD-L1 expression.
So you're not using you're not routinely testing your patients for PD-L1?
So no, we don't routinely test PD-L1 because we don't know which is the antibody, which is the cutoff, and the eyes of the pathologists are also different. So I think that, and then if they have to see the PD-L1 expression on the tumor cells, on the immune cells, the proportion score, I think that we will need to educate the pathologists more. So nowadays in Europe, nivolumab is approved independently from the from the PD-L1 status, so we give the drug.
So nivolumab is your de facto regimen.
Yeah.
Outside, you don't routinely test for PD-L1.
Exactly.
Chandra, are you testing for PD-L1 routinely in your patient population?
Yeah, we are testing, but we are testing in a small group of patients. So if we have the biopsy specimen and we are able to do it, we do test it. So if the PD-L1 is positive, we give pembrolizumab, and if it's not, then we give nivolumab.